Hello, this is our presentation on preeclampsia and its prevalence amongst African Americans by Shauna, Jasmine, Dana, and Luis.
Hey everyone, I'm going to start by doing a little refresher for y'all. Preeclampsia is a significant cause of maternal morbidity and mortality, affecting up to 8% of pregnancies globally. Although precise etiology is still under study, the literature suggests that vascular changes reduce placental perfusion and affect the remodeling of spiral arteries to create the hallmark feature of preeclampsia. The new onset elevation in blood pressure is the main factor. Additional features include nervous system manifestations, liver subscapular hematoma, and a sudden onset pulmonary edema. Eclampsia, characterized by convulsions, is the most severe manifestation of preeclampsia. Fetal impacts include fetal growth restriction, oligohydramnios, I just butchered that, I'm sorry, placental abruption, and non-reassuring fetal status, all of which may increase the risk of preterm delivery. Preeclampsia is screened by taking BP at each prenatal care visit to allow for early identification and diagnosis. The laboratory values associated with severe preeclampsia include thrombocytopenia, twice the upper limit of normal concentration of liver enzymes, serum creatine above or equal to 1.5 mg, or a doubling of serum creatine concentration in the absence of other renal disease, and evidence of proteinuria. All pregnant women should be screened for preeclampsia. Prior health conditions such as a patient history of eclampsia or preeclampsia, particularly early onset preeclampsia, maternal vasculopathies, including type 1 or 2 diabetes mellitus, chronic hypertension, and renal or autoimmune disease are associated with an increased risk of preeclampsia. Other conditions include multifetal gestation, nulliparity, obesity, low socioeconomic status, advanced maternal age, and African American race. Next slide, please. Unfortunately, preeclampsia incidence in the United States is rising. The two major studies I found regarding this topic, Vasanya et al. And Boyk et al., I just butchered those names, I apologize, both claim that between 1987 and 2004, there was a 25% increase in the incidence of cases. They further went on to demonstrate how, in the United States, preeclampsia is more prevalent among Black or African American women than white women, and that this Black-white gap is widening. The disparity in preeclampsia risk between African American women and women of other races is a robust finding. They speculated that the increased incidence in African American women is thought to be secondary to a variety of factors, including African American women being disproportionately affected by risk factors of preeclampsia, such as hypertension, diabetes mellitus, obesity, socioeconomic status, and unequal access to adequate prenatal care. Preeclampsia leads to a 1.7-fold increased risk of cardiovascular-related mortality. They also mention a few other studies which help support these claims, such as Tucker et al., who found that even in a population in which the prevalence of preeclampsia in Black women was only slightly higher than in white women, the maternal fatality rate was significantly higher in Black women. Finally, the racial disparity in maternal fatality has also been documented more recently in other studies. Two studies, one published by Shaw et al., which was labeled African American Women at Increased Risk of Inpatient Mortality, and one by Bibbins Domingo et al., called Case Fatality by African American versus White Race, found an average mortality rate of 73.5 for African American women versus 27.4 for white women per 100,000 cases. Next slide, please. Have I put y'all to sleep yet? If not, let me leave you with one last thing that I found interesting. In one of the previous studies I mentioned, they discovered that in New York City, both North African women and Sub-Saharan African women have a lower risk of preeclampsia than in African American women, but higher risk than non-Hispanic white women. Although foreign-born North African women had lower odds of preeclampsia than U.S.-born North Africans, the finding was not significant. These limited data tentatively suggest that the U.S. environment increases preeclampsia risk in those of African ancestry, which to me makes it seem like there's something in the water, y'all. Or our diets. Go figure. Next slide, please.
When it comes to beliefs and practices, people from this culture perceive children as special gifts from God, the Supreme Being. They also believe that women should pray to prevent pregnancy complications and that they should be more cautious since extra forces or evil spirits might come to play during pregnancy. Because of this, they wear certain bracelets as a form of protection against evil forces. Most women also seek prayer support from pastors during pregnancy, and a number of religious artifacts are used by women to enhance their protection and ensure safe delivery. Some artifacts used in pregnancy and labor are anointing oil, blessed water, blessed white handkerchief, blessed sand, and the Bible and rosary. For antepartum considerations, it's important to know that diet is heavily influenced by their culture. Some women increase their water intake, consume bitter herbs and roots to induce vomiting in order to purify the woman's bloodstream and cleanse her stomach. They might also avoid certain foods such as sweet potatoes, bananas, fatty foods, and salt, particularly in the third trimester. They believe that doing this prevents stillbirth or having a big baby. For traditions and beliefs, most women seek prayer support from pastors during pregnancy, and they believe that pregnant women should not eat or drink in public to avoid the effects of evil spirits. Some prevention and education to provide: if they are planning to use herbs and roots, they should consult with their doctors as this may interact with their medication if they are taking any. Certain dietary restrictions may also be harmful for the mother and the baby. The patient should be educated about proper nutrition to make sure it does not increase their risk for preeclampsia. If they mainly seek advice or support from pastors, encourage them to visit their doctor for extra maternal monitoring, especially if they're experiencing signs and symptoms of preeclampsia such as nausea and vomiting, headaches, swollen extremities, right upper belly pain, or feeling unwell in general. We should also consider their beliefs, but emphasize the importance of food intake, especially if the mother has type 1 or type 2 diabetes, since not eating or drinking anything in public may cause harm to both the mother and the baby. For intrapartum considerations, it's important to note that, in addition to prayer, some women sing quietly during labor. And while singing, some women think about the severe pain associated with the labor rather than the unborn baby. For this, nurses should be mindful of the mother's ritual and practice, and try to avoid interrupting as much as possible when monitoring both mom and the baby. When it comes to delivering the baby, C-section is usually avoided due to fear of death during surgery and stigma from their family. The patient should be educated on possible C-section if complications arise and it becomes less safe to deliver vaginally. For preeclampsia without severe features, there are several things that should be monitored. This include monitoring the mother's vital signs frequently and providing a quiet and non-stimulating environment. Watching and closely monitoring the fetal heart rate and the neurostatus for hypoxemia, impending seizure activity, or increased intracranial pressure. For preeclampsia with severe features, some possible medications that may be given to the mom are oxytocin to induce labor, antihypertensive to lower the blood pressure, and magnesium sulfate to prevent seizures. The patient should be monitored for magnesium toxicity, respiratory depression, hypocalcemia, and hypotonia. Calcium gluconate should also be readily available in case toxicity occurs. Also, it's important to note that decreased fetal heart rate variability is a normal effect of magnesium, and seizure precautions should be implemented since preeclampsia can progress quickly into eclampsia.
Postpartum considerations. Most cases of postpartum preeclampsia develop within 48 hours of childbirth, but postpartum preeclampsia sometimes develops up to 6 weeks or later after childbirth. This is known as late postpartum preeclampsia. Postpartum preeclampsia can be difficult to detect on your own. Many women who experience postpartum preeclampsia show no signs or symptoms during pregnancy. Signs and symptoms of postpartum preeclampsia are typically the same as symptoms of preeclampsia prior to delivery and might include high blood pressure, proteinuria, severe headaches, changes in vision, including temporary loss of vision, blurred vision, or light sensitivity, pain in your upper belly, usually under the ribs on the right side, nausea and vomiting, shortness of breath, and decreased urination. Complications of postpartum preeclampsia include postpartum eclampsia, pulmonary edema, stroke, thromboembolism, and HELLP syndrome. To help prevent some of these postpartum complications, would be discussing the signs and symptoms of preeclampsia with your doctor, taking baby aspirin to prevent preeclampsia during your next pregnancy, and having an active lifestyle and healthy diet. Newborn considerations. Preeclampsia is a major cause of fetal morbidity and mortality, as well as preterm infants. Infants born preterm due to preeclampsia face a higher risk of some long-term health issues, mostly related to being born early, including learning disorders, cerebral palsy, epilepsy, deafness, and blindness. Infants born preterm may also have to be hospitalized for a long time after birth and may be smaller than infants born full term. Infants who experienced poor growth in the uterus may later be at a higher risk of developing diabetes, congestive heart failure, and high blood pressure. The early postpartum period is when women who experience preeclampsia are at a higher risk. Much of this risk can be lessened with effective blood pressure control. In general, drugs should be chosen for their effectiveness and that have low to no risk for the baby during breastfeeding. For severe hypertension, combination of drugs with different mechanisms of action may be needed. These include beta blockers that effectively lower heart rate, vasodilators that open small blood vessels, and diuretics that help get rid of excess fluid through urination. These medications can help protect both mother and baby during postpartum preeclampsia and should be monitored by your healthcare provider.
Our nursing diagnosis for the mother with preeclampsia is decreased cardiac output, related to increased systemic vascular resistance secondary to severe preeclampsia, as evidenced by blood pressure greater than 160/110 on 2 or more occasions, dyspnea, and crackles on auscultation of the lungs. The expected outcome is that the patient will have improved cardiac output as evidenced by blood pressure of less than 140/90 and lack of dyspnea throughout the remainder of her pregnancy. The interventions for this nursing diagnosis include, number 1, carefully monitor blood pressure every 15 minutes during the critical period until the blood pressure stabilizes and reaches below 140/90, and then every 4 hours. Increased blood pressure causes increased peripheral resistance, which prevents blood from reaching vital organs, including the heart. Also, a rising blood pressure may indicate worsening preeclampsia. Number 2, administer antihypertensives as ordered. Some commonly used are hydralazine, labetalol, and nifedipine. These reduce systemic vascular resistance, lower blood pressure, and improve cardiac output while maintaining utero-placental blood flow. Number 3, initiate bed rest in lateral recumbent position. Bed rest should be implemented because it reduces blood pressure, which improves venous return and cardiac output, while also maximizing blood flow to the placenta. Our nursing diagnosis for the fetus of a mother with preeclampsia is risk for injury, as evidenced by inadequate remodeling of maternal spiral arteries, resulting in decreased utero-placental perfusion. The expected outcome is that the baby will remain free of injury throughout the remainder of the pregnancy, as evidenced by absence of fetal distress and vital signs within normal limits upon delivery. The interventions for fetal risk for injury include, number 1, monitor fetal status by recording fetal movement counts, non-stress testing, and serial ultrasounds. Report any signs of fetal distress. These help to evaluate fetal growth and amniotic fluid volume to determine fetal well-being. Preeclampsia increases the risk of placental abruption, preterm birth, intrauterine growth restriction, fetal distress, and fetal death. Number 2, administer magnesium sulfate IV to the mother. First, a loading dose of 4 to 6 grams over 15 to 30 minutes, followed by a continuous infusion of 1 to 2 grams per hour as ordered. This is given to prevent maternal seizure, which can compromise fetal oxygenation, causing hypoxia and potential death of the fetus. Number 3, administer betamethasone IM injection. 2 doses of 12 milligrams should be given to the mother 24 hours apart as ordered for the gestation of less than 34 weeks when the mother has severe preeclampsia and prepare for delivery. Treatment with betamethasone can help to mature the fetus's lungs to prepare for birth. The lungs of premature babies are not fully mature, putting them at high risk for respiratory distress syndrome. Corticosteroid therapy reduces this risk, as well as for necrotizing enterocolitis, and most importantly, reduces the risk for death. The CDC states that when maternal high blood pressure prevents adequate oxygenation of the fetus, the baby should be delivered prematurely. Delivery is necessary because it is the only cure for preeclampsia. These last few slides contain our references and conclude our presentation. Any questions?